Okay, thank you. So let me share my screen and so everyone, can you see my screen? Gaurav?
Yes, sir. Yes, sir.
Okay, fine. So good morning, all of you. And we are going to discuss today delayed or chronic Monteggia fracture dislocation and management principles. In previous session, Dr. Tushar Agrawal talked about acute Monteggia fracture. The delayed Monteggia is a challenging problem, but you will come across this very frequently because this is the most frequently frequently missed fracture, that is Monteggia fracture dislocation. When we are dealing with this, we have to answer a few questions. That what is the natural history of untreated Monteggia? What would happen if we don't treat Monteggia dislocations? The second question is, how much old is safe to reduce a chronic Monteggia? Meaning that how much time would have elapsed, and then you think that I should not touch this because it's a very old injury. There was a trend that people used to do only indirect reduction. So they were performing only ulnar osteotomy without opening radiocapitellar joint. So the question is, can we reduce Monteggia without opening radiocapitellar joint? And can one use radiocapitellar wire as a definitive treatment? And what is better, acute or gradual ulnar correction? And where we should perform the osteotomy? So in my subsequent talk, we will discuss these points, and at the end we will discuss the question answers. So what's the natural history of missed Monteggia? There are a lot of literature that we should treat Monteggia because it leads to a lot of issues. Dr. Mehta mentioned that the radial head which remains out of the confine of the joint and undergoes AVN, and it gets deformed, and it might lead to progressive cubitus valgus and pain and instability at the elbow. There are papers which also show that long-standing Monteggia dislocation leads to subluxation at the distal radioulnar joint, and there are reports of median and ulnar neuropathy. So because of all this, we intend to treat chronic Monteggia if they are presented well in time. Now, this is a 32 years old lady who sustained an injury at the age of 11 years. And then she took treatment from bone setter. So this was almost 21 years old injury. And this X-rays were shared by my friend. This lady comes every 3 monthly to my friend, an orthopedic surgeon, for elbow pain. She has some degree of cubitus valgus, as you can see on the X-ray, but more pronouncing, she is developing early radiocapitellar arthritis. So her pain and problem would worsen. So this is the natural history of untreated chronic Monteggia. Now, how much old is safe to reduce? And there are we must learn from the literature, and there are very nice papers. One of them is from Japan, and in this series they have treated 22 patients, and 10 patients were more than 3 years old injury. So if we see in details what happened to these 10 patients, 7 out of 10 patients had developed radial head deformity, and 6 out of this 7 radial head deformity patients had subluxation on subsequent radiograph and arthritic changes. So out of 10, 6 patients had arthritis when they were treated more than 3 years old, meaning that 60% cases get arthritis if you treat them when they have elapsed 3 years from the index injury. And they also found that children more than 12 years has poor or fair outcome. So they relate the patient's age with the poor outcome. So one message from this paper is, if it has more than 3 years time gone, we have to tell family that there are high chances the child might develop arthritic changes. Another paper which was published in JCO, they found that poor result in their series when index injury happened before 40 months, but they did not find any age correlation. The next question we must answer is, can a missed Monteggia be reduced by only ulnar osteotomy or indirect reduction? I've always compared a radiocapitellar dislocation with a congenital hip dislocation or developmental hip dysplasia. Have we ever tried reducing DDH just by femoral osteotomy? We have always performed an open reduction first, and then if required, we have performed femoral osteotomy. Similarly, when the radiocapitellar joint is dislocated for a long time, we have found a lot of fibrosis. Annular ligament is lying in the radiocapitellar joint. And sometimes even after opening, it is very difficult to milk the radial head through the contracted annular ligament. And so it is very difficult to achieve and obtain and maintain reduction by just an ulnar procedure. Let's see an example. This 6-year-old boy who had 6 months old injury, and you can see there is olecranon injury and ulnar anterior bowing, that the Mubarak line which Dr. Tushar Agrawal mentioned last time. You can see it's disturbed and there's an anterior dislocation. So the primary surgery done by orthopedic colleague was only ulnar flexion osteotomy. So the ulnar realignment osteotomy was done, but if you see the radiocapitellar line, it is still anteriorly dislocated. So the surgeon thought that now I need to shorten the radius and flex lengthen the ulna and flex it. So they have done lengthening, flexion, distraction osteotomy, and this time they placed an iliac crest graft, but the result is same. They did not open the radiocapitellar joint, and although they found intraoperatively well-aligned radiocapitellar joint, on post-operative X-ray, the radial head is subluxated. So the main issue is probably they have not addressed the radiocapitellar obstacles of reduction. There are a very sporadic historic review, like this paper, which has only one case by Exner, and they have done external fixator assisted reduction, and they claim that the reduction was maintained over a period of time. Another paper from our own Dr. Venkat Das from Ganga, he has published this technique of sliding angulation osteotomy without opening radiocapitellar joint. But my last communication with him, quite a few number of patients had shown post-operative subluxation in their series. So this osteotomy technique is fabulous. One can try this, but one should address the radiocapitellar reduction first. So anyone in the group, do you consider, do you do chronic Monteggia without opening radioulnar? Dr. Anil Agrawal is here. Dr. Anil, what is your approach?
Open reduction is always required.
Right. Raman is here. What is your approach, Raman?
When fixators don't work well.
Yeah, so that is right. I have a similar experience, the pin track issues, and irrespective of fixator, what I'm suggested that they open the joint first. Fine. So let's move ahead. Now the next question to all the fellows, that what is the sequence of treating chronic Monteggia? You do ulnar osteotomy first or radiocapitellar open reduction first? We discussed this point. Dr. Anil, you do the radiocapitellar open reduction first, right? Right. So what is the conventional way to reduce chronic Monteggia? So let me take you through that surgical technique, and then we'll discuss few more points. So this is a delayed Monteggia fracture dislocation. This is a 8-year-old boy who sustained ulnar fracture before 1 year, and he presented a prominent radial head on the anterior cubital fossa. His flexion was limited, and there was an ulnar bow. As you can see, there is a bit of calcification of annular ligament. This was an anteromedial dislocation, as you can see. And this is a comparative view. Now, what we take is a extensile Coker's approach. And so let me mute this video first, otherwise it will keep on. Anyways, let me play this. So incision should be centered over the lateral condyle and then go through the anconeus and extensor ECU interval. You can go for, in the beginning, you must dissect the posterior interosseous nerve and always go between brachialis and brachioradialis. I learned it from Peter Waters because in one or two cases in his series, he developed post-operative PI and palsy. So his practice was to decompress the PIN. You can see the PIN, and with the pronation maneuver, this PIN gets stretched. Once you release the PIN, now the next step is to address the annular ligament. And I always advise fellows to, when you see an annular ligament, it is a white structure, go at the top of the annular ligament, because there will be a rent, there will be a hole through which the radial head has come out. And we have to enlarge that hole either by putting a multiple radial cuts or by enlarging it. And with your dura, you have to bring the radial head through that hole of annular ligament. And you have to milk down the annular ligament over this. So it's usually annular ligament is here, radial head is here. We may do a mistake to cut the annular ligament from the lateral side. We don't have to do that. We have to go at the top, widen it, and then you bring this down over the radial head. That should be the procedure. Now look at this. In this case, how we have done it. You will see the top view in a moment. So this is the annular ligament which is lying in the radiocapitellar joint. I had made multiple radial cuts and I have milked this down the radial neck, see, and so the radial head comes in front of capitellum. And once it comes in front of capitellum, you have to check the stability. If it is unstable, then you have to go on the ulnar side. You do ulnar osteotomy and check reduction. Sometimes after doing the ulnar osteotomy, what I do is I put a temporary trans-capitellar radiocapitellar wire, which is temporary, by reducing radial head completely. And once you put a trans-capitellar wire, see what is the position of ulna fragments. So in that position, you have to fix the ulna. This is just how we do in a neglected DDH cases. So we put a wire across and then see what is the position, how much of shortening is required, how much of derotation is required. Similarly, here you can put a temporary trans-capitellar radiocapitellar pin, and then I use a double stacked semitubular plate which fits very well onto the dorsal surface of ulna. Why double? Because sometimes when you try to fix the ulna in a flexion position, the semitubular plates may lose the pre-band which you have given. That's why I tend to use double or a stacked semitubular plate. In this case, you can see I require to do only 10-15 degrees of flexion osteotomy of ulna. And then once you have done fixed the osteotomy, you remove the wire and check the stability both in flexion, extension, as well as rotation. The radial head would remain located in flexion. What is important is what happens in extension, because in extension, the biceps long head has a tendency to pulling it out again. So you have to check in extension and pronosupination, it should remain. So you can see here. So this is, you can see in full flexion extension, the radiocapitellar joint remains in aligned and even in pronosupination. In that point, you may take a couple of small stitches through the annular ligament. Do not make it very tight. Okay. And this is the final follow-up at 3 years. He has some limitation of pronation. You can see this boy got married a few months back. So, right. So let's move on to the next. Now, any comment on the technique, Dr. Anil Agrawal or anyone, you want to comment on the technique or question? We can take question later. Yeah, Gaurav?
Yes, sir. Very nicely done, sir. I follow the same, and I first go and open the joint through this extensile approach. See the status of annular ligament. Most of the times, as you said, that it is like that only, and just try to milk the head. Sometimes I have to make some to expand that hole which is shrunken, and then I go to ulna, do the osteotomy, then reduce the radial head, and then fix the ulna. So I follow it copy book.
Right. So, what is the site of osteotomy? That's an important question. Whether, because sometimes you would see that cora is, or the plastic deformation, cora is way distal. So the preference is to do osteotomy more proximal, because proximal osteotomy has more pull on the interosseous membrane and it has a more direct reduction force on the radial head. So osteotomy should be performed proximal rather than distal. And there are two types of osteotomy has been described. Ulnar flexion osteotomy, if the radial is not too much proximally migrated, you can just do a flexion. And if you have quite a neglected proximally migrated radial head, then you can perform the distraction osteotomy. One can take bone graft from the iliac crest. So based on your preoperative X-ray, you may consider, you may think to make your osteotomy and graft site ready. Okay. And as I mentioned, the proximal osteotomy is preferred over the cora. Now, another burning question is annular ligament reconstruction necessary? Now, the literature says that annular ligament reconstruction, there was no difference in the outcome with or without annular ligament reconstruction. One of the paper is from Dr. Atul Bhaskar. Literature, there is no consensus. Those who are recommending, they are suggesting to use palmaris longus over the triceps fascia, because triceps fascia has a higher rate of contracture and fibrosis compared to palmaris longus. And then there are papers showing complications of annular ligament reconstruction, like restricted rotation and recurrent subluxation. So in the last IFIX, Dr. Sheetal Parikh was there, and we have a big debate on this, but we had a consensus that there is no specific or consensus on the role of annular ligament reconstruction. Most of us, they rely on the radial capital reduction followed by ulnar osteotomy to maintain it. And if needed, you may just take a small riffing stitches, but not make it too tight. Should trans-capitellar wire be used to hold the reduction? Sometimes you may find that the radial head shape is not good, and even though you have done all the procedure, radial head is a bit subluxated. So there is a practice in many centers, they use a trans-capitellar wire temporarily for a few weeks, but the literature says that use of trans-capitellar wire on a regular basis leads to increased stiffness. There are papers where the wire has broken inside the joint, and then it becomes very difficult to retrieve that wire, and you need to dislocate the joint to retrieve the wire, a broken wire. So that's a most devastating complication. And then there are papers which have shown that there was no difference in outcome when it was used for unstable situation. Either you use or don't use, it doesn't make a difference in the outcome. So the consensus is trans-capitellar wire we do not use, because there are if it gets complicated, then it's not a salvageable situation. Yes, but as I mentioned before, you can use it temporarily to template your osteotomy. So you put a wire across and see what the position of ulna is. It what flexion it is, or it is flexion distraction. So accordingly, you can template your osteotomy, and then you remove the wire. That it can be done. Now, if you are you venture to do a very old case like this was a 14 years old and 8 years old injury, where I did open reduction. It was a very stiff elbow, and the radial head was not coming down. So I thought of doing I did ulnar osteotomy. And even after doing ulnar osteotomy, when I pulled the radial head down to put a temporary K-wire, I was not able to bring the radial head down. So in this situation, I had to perform a radial shortening osteotomy. So I performed a radial shortening osteotomy from the distal metadiaphyseal junction and fixed that with a rush rod. And then we could achieve the radiocapitellar reduction. And fortunately, this boy did well. So this one should keep in mind. If you happen to fix an older injury, sometimes you might need to reduce the length of radius. You might have to shorten the radius. And finally, what is the future of Monteggia fracture management? Now we see more and more neglected cases, and some of them have very severe restriction of chronosupination after surgery. And we contemplate that why this happens when the reduction is fine. And we found that the radial notch of ulna may get obliterated when the radial head remains dislocated for a long time. There is periosteal elevation at the time of index injury, and which also obliterates the radial notch of ulna. And the radial head undergoes AV, and sometimes like coxa magna, they undergo hypertrophy. So that size of radial head may not match the size of the radial notch of ulna. So we have to see these things beforehand, and for that, to understand the anatomy of radial head and ulna more, a 3D printing of these injuries are coming in picture now. We do 3D printing and then see by templating whether this radial head will fit well in front of radial notch or not, and what amount of ulnar and what sort of ulnar osteotomy would be required. Dr. Taral Nagda from Mumbai has been doing good work on it, making 3D zig pre-operatively, but this has been used extensively across the world, and this is probably the future of fixing the Monteggia fractures and providing good outcome, and to forecast which patients will do well and which will not. So I think I'll stop here, and we can discuss this issue now. I'll stop sharing. How can I stop sharing? Okay. So Gaurav, do we have questions?
Yes, sir, we have a few questions. So the first question is by Dr. Anil, sir. He's asking how to put trans-capitellar wire.
Yeah, so what you do is the radial head you have placed in front of capitellum after doing ulnar osteotomy, and then you or your assistant in maintaining that reduction, and then percutaneously you put a wire through the capitellum just from besides the ulna, and you could see in that slide. Or what you can do is you can pass a wire, let it come out of capitellum, then withdraw it, and then you reduce the radial head and transfix it. So it's from the posterior approach you do it.
Right, sir. Another question is by Dr. Yakub. Sir, will DRUJ be under tension when we do distraction osteotomy? Or when in case of ulnar lengthening with LRS, is there a chance of distal radioulnar joint subluxation gradually?
So we have done many, and we have not seen Druge problems, and the amount of distraction which was required in a few cases was not more than 1.5 centimeters. And this radial head is already shortened, so once you lengthen it, the things are placed. So we have never seen a problem in Druj on follow-up.
Right, sir. Sir, so one more question from my side is that you have done a case more than 8 years old dislocation. So we usually see that the radial head becomes convex after 3 years of dislocation or prolonged dislocation. So what is the indication of reducing a more than 3-year-old Monteggia or radial
Yeah,
head?
so we should not, we should communicate with the family. Now, this fellow had a progressive cubitus valgus and he had pain on writing. So he had quite a significant symptoms. That's one. And although it was 8 years old, the radial head top was not looking like a convex. It was looking like a saucer. So I thought that I should try, but the moment I opened it up, I was worried that it was not moving at all. So I got confused on table that what to do. Now I have shortened, I've done the ulnar osteotomy. I have done all the open reduction thing, but still I'm not able to move the radius. So this we just use this DDH principle and I was successful. So, but more than 8 years it's associated with a lot of stiffness also. So we can avoid if the symptoms are not significant enough.
Another question by Dr. Anil is what is the modality if the head is convex? In continuation to my question.
So like if a child is very young, and there are papers from Japan and China that they have tried to reduce even congenital posterior dislocations. Now we know that those are convex heads, and in young children they got remodeled to some extent. When it comes to older children, a resubluxation is a rule, because it will not fit the shape of the capitulum. But if you're a very young child and then you do annular ligament reconstruction, you keep it transfixed with a wire for some time, then it may remodel to some extent. But I would, convex heads have their own problems of resubluxation and stiffness.
Right, sir. One more question by Anil, sir. Do you take into account the overlap of radial head while planning ulnar osteotomy?
Yeah. So that is a paper from Japan, and they have templated, overlap, the radial head overlap. But what I have felt is just based on amount of overlap, you think that this much of distraction would be required. But many times overlap is due to interpositioning soft tissue. Once you take the annular ligament out, once you take the fibrosis out, many a times the radial head jumps in. So although I take in account and keep this iliac crest site open, but I have found that we cannot template that this much of lengthening would be required just looking at the x-rays. Many a times in x-ray it looks proximally migrated, but it jumps in well, and we just end up doing ulnar flexion osteotomy. We even do not need distraction. Yeah. So
okay, sir. So he's also asking for how much gap you use bone graft.
So as I mentioned, if your distraction is more than 1 centimeter, then you have to put in crest graft. Otherwise, when we do a flexion osteotomy, sometimes on the concave side it is opening about 1 centimeter, and then we don't graft it, but still it heals well. But if it is more than a centimeter, then we can put a graft.
Okay, sir. So, sir, what is your post-op rehab protocol? Because many a times you see that they become stiff.
Yeah. So we as you know that we apply them, we put them in a above elbow plaster or slab for 2 weeks, then remove the stitches and apply a plaster for 2 more weeks. So we immobilize them for 1 month. In what thing you should take care is when you ask them to do physiotherapy. I mean, I don't advise a conventional physiotherapy. I advise an active movement by patient, and they should not suddenly jerk their arm in full extension, because that might lead to anterior dislocation because of stretch of stretch of biceps. So we advise a gradual active range of motion, and the family is standing besides the child, but they don't have to do anything. The child himself has to do the exercise flexion extension. We give them cylindrical object and ask them to do pronosupination also. And most of the children, their restricted elbow flexion improves as soon as we put the radial head back in position. So get elbow flexion extension is never a problem. What problem they have is sometimes they have restriction of pronation. So they do not have terminal pronation, but they easily compensate with shoulder. So do not hassle or do not be very, what do you say, aggressive in post-operative rehab. They have to do by themselves. Explain them a rule that most of the patient gain 90% range of motion within the first year of surgery. And do not send them to physios. Ask them to do active exercise and let parents monitor it. That's what protocol we use.
Sir, one last question, which is not exactly from this topic. What is your management for congenital radial head dislocations when they come in the first few months of life?
I have read papers that people have tried and reduced it. But I have never tried to put them back, because there are also literature showing that when you try to put a convex head in position, it ends up into a lot of stiffness, and some of them are better without the heads in position. So they have their limitation of movement is more when you try to do heroic intervention and put it back in. And if it gets further subluxated, sometimes the subluxated heads become painful also. So it's better not to touch that. That is my practice. But there are some centers across the globe, they try to put them in here.
Right, sir. So we are done with the questions, and
Perfect. So thank you very much. We do not have cases today. I had to wind up quickly. We have in theater a few cases today. So any question you can put in our fellows group and we'll try to answer. We will post this interesting literature. Dr. Srinam or Dr. Meet would post in our group, and we'll meet next week with some other topic. Thank you, Gaurav, for moderating. Thank you very much.
sir.
Bye, everyone.